Good. Hello, everyone. This is Dr. Pritpal Singh, an MBBS MD from CMC Ludhiana. And during my last session on the outcome assessment or outcome measures, I had highlighted about various aspects that we need to look into. So today we'll proceed further and we'll have just a brief idea over what are the various parameters that we can go ahead and how all we can assess the outcomes on a in a research process. So without and I hope that I'm able to clear some air on this particular aspect of outcome measures, which could be helpful to all the researchers. That is my effort. That would be my effort from my side. And if there are any queries pertaining to the session today, you could always so if there are any queries pertaining to this particular session, I would be glad to solve those queries, and you could always inbox me and I'll definitely get back to you. So I'll just start my presentation on this, and we can proceed ahead with this particular aspect of outcome measures. And when we started with the research methodology, the aspect that I was talking about in the research methodology was that research methodology process, you need, it is an hourglass approach where your introduction is broader, your methodology and result is narrowed down, and then discussion against broaden ups. And we have the PICO format for the research question, that is the population, the intervention, the comparator, and the outcome. And sometimes we add T to the PICO, making it PICOT, that is the measure of time. And when we were in the last of my sessions, what I wanted to evaluate, I'll just start with a brief recap of what we had discussed, or what I was trying to highlight in my last session was that for when we are talking about an outcome measure, it is to improve patient safety. It is also important that we evaluate the effectiveness of solution in real life settings in terms of their impact, acceptability, and affordability. And we started with several methods for evaluation, where we started with definition of an outcome, which was a measurable individual, family, or community state behavior or perception that is measured along a continuum and in response to a particular clinical intervention. And we talked about this particular cycle where we are trying to measure harm, we try to understand the cause, identify the solution, go for the solution, we evaluate the impact, then we translate into safer care. Again, this cycle keeps on repeating. We again measure the harm, understand the causes, identify the solutions, and this is how it proceeds further. We talked about the 6 Ds of outcome research, which include death, disease, disability, discomfort, dissatisfaction, and the cost, which is interpreted as dollars. And there are why do we want healthcare research in quality? Because we want to assess what works, what doesn't work, and at what cost does it work, and when at what time does it work. So, and I highlighted this particular aspect that the outcome research has its own language. There are no uniform definitions for it. And it is basically a scientific study of the results of diverse therapies used for particular disease, condition, or illness. And outcome research or outcome measures are directly linked to evidence-based medicine. That is what we were talking about. So the conventional clinical measures that we were talking about in the last session were mortality, disease or treatment complications, the pathology, the physiological or lab abnormalities, deformities, and the signs and symptoms. And this is where we were, these are the various categories of patients' outcome with assessment scores and examples. These patients' outcome could be divided into 4 categories. It could be clinician reported, it could be a physiological changes, it could be caregiver reported, or it could be patients reported. Now, when we are talking about the outcome assessment for a clinician reported, he would look into the global impression, he would look into your observations, and he would look into the test of various functions that he's been doing. For physiological, we tend to go for various parameters, such as maybe just a hypothetical example of forced expiratory volume 1, glycosylated hemoglobin, and tumor size. And for caregiver, we talk about, whenever we are talking about caregiver, the immediate person who is taking care of the patient, it basically depends upon the amount of dependency that this particular patient has on the caregiver, and how this particular dependency tends to hamper the functional status of the caregiver. For patient, there are various parameters, because ultimately it is the patient who has to tell us and who will be our main guiding force. And most of our parameters that we tend to assess are mainly patient reported, and these are global impression, the functional status, well-being, the symptoms, improvement in symptoms, the health related quality of life, satisfaction with treatment, whether there was treatment adherence, and utility or preference based measures. Now, proceeding further to this, which first what we need to do is we need to outline our study. Now, what do we want to, how do we outline? What was the presentation at the baseline of this particular patient, and what was the condition? Did this patient receive a treatment for this particular condition, and what was the response to this particular treatment? So if I go back, it is again the same thing. This clinical outcome or this plan could be interpreted in terms of clinician reported, physiological, caregiver, or patient reported. So patient presents with a condition, he receives a treatment, and a response is experienced to treatment, and this response could be interpreted. It could be interpreted in the term of the physician, it could be interpreted in terms of caregiver, it could be interpreted in terms of physiological parameters, or it could be interpreted in the terms of patients. Now, before we proceed to these various things, there are two things that we need to have a clear aspect, or we need to look into before we go for outcome measures, is the various biases and confounders. So what is a bias? A bias is when you are trying to compare components that are there are not sufficiently similar. So this bias could be selection bias or treatment bias, which is most often seen whenever we are going for maybe let's say, I'll give you an example of selection bias. There are two treatments. One is a conventional treatment which has proven efficacy, and the other one is the new treatment. And supposedly, if the physician is not blinded for this particular treatment plan, there are all possibilities that physician would tend to go for a conventional plan which has been proven. He would not prefer to go for a plan, a new drug, or a new treatment. Similarly, the treatment bias could be other way around. We could base our uh, patients, or we could divide our patients depending upon the severity of their illness, where we tend to find that a patient who is severely sick, we might change the treatment of that particular patient. So these are bias. And then there are various confounders that can always have an impact on your outcome measures. What are these confounders now? These confounders are variables that are thought to cause an outcome, and it is not actually responsible because of the unseen effect of another variable. So this bias confounders could be the age, it could be the gender, it could be the ethnicity, it could be the race, or it could be comorbidities. Comorbidities like diabetes and hypertension. Supposedly, if I talk about comorbidities, and I want to compare, maybe let's say I want to compare the severity of the disease, and I don't take into consideration one of these comorbidities, there is all possibility that I might miss them. And if I include most of my patients with diabetes mellitus, the severity of disease might vary, or maybe hypertension, the mortality rate or the mortality data might vary if I am having one particular group which has a large number of comorbidities. So these are two things that we need to take care whenever we are talking about an outcome research, and this has to be pre-planned. Now, before we proceed to the final outcome, we need to ask ourselves, how do we know that the care that we are providing is safer? What is the available data with us? What is the frequency of harm? What is the prevalence of appropriate care? Is there any change in practice in response to learning? And is there any improvement in safety culture? So all these things, they too tend to interfere with your outcome research. Now, to have an outcome research, what you need to do is you need to have a baseline data, a baseline assessment at the beginning of a particular study. And this assessment would include your inclusion criteria. How did you define the disease? How did you define the severity? Did you follow, if you were looking for a cancer study, did you follow the TNM status, TNM classification? Or if you were talking about sinusitis, what was the parameter that you were following? Was it Lund-Mackay or Harvard, or are the results reproducible? Did you look for comorbidities? If we were talking about disease severity, as discussed in the previous slide, did we go for like a parameter like an adult comorbidity evaluation 27? This is the instrument for evaluating comorbidity in cancer patients. Now, to assess the quality of care, we need to follow Donabedian flowchart, and this flowchart consists of three components: the structure, the process, and the outcome. How does this particular structure, process, and outcome interpret itself into the safety culture? There is a pathophysiological state of the disease. There are certain symptoms associated with this particular disease. These symptoms tend to affect the physical and mental health of the patient. And what are the various assessments, whether the quality of life was significantly affected or not? Now, these are the various domains of quality that we would like to assess for an outcome. These would be the safety of the intervention, the effectiveness of the intervention, whether this intervention is patient-centered, is it efficient, what is the timeline where this is efficient, and the cost, the D, the dollar, the last one, is it equitable? So all these things, they do come into play. Now, the outcomes, as we were talking about, could have different perspectives. Now, we talked about four perspectives for an outcome, and we'll just try to highlight these four perspectives a bit further. The four perspectives that we were talking about was the the clinician's response, the caregivers, the physiological, and the patient's approach. When we interpret them as different perspectives, this could be the clinical perspective, the patient's perspective, and the societal perspective. The clinical perspective, obviously, we know whether the severity of the disease decreased or not. Now, for the patient's perspective, it is the health status of the patient, whether his quality of life was improved, whether he was satisfied by the treatment or not. And when we talk about the societal perspective, is it of any utility, and is it cost effective? Safety measures always are an important parameter for assessment of an outcome. What harm do a particular intervention cause? And for that particular harm, what is the appropriate care that has been to be taken? What is the process? Has this particular care been explicitly defined? What is the learning environment out there? And what is the safety culture that is being followed? Let's talk about certain examples out here, and maybe I'll be able to clear some air on this particular aspect. So the first one is whether we want to measure an appropriate care process. Like an example is clean care is safer care. Measuring the learning, you could go for an audit of various actions taken. For a prospective study, 6-month long cohort study for cost analysis, Bates is an example. Cross-sectional study, case control study, you tend to identify the cost, Khan is an example. Now, evaluation could be direct observation, indirect observation, or it could be an outcome. So what is this direct observation? It is a proportional of appropriate hand hygiene if we are talking about safety per total number of hand hygiene opportunities. Indirect measurements would be the volume of alcohol-based hand rubs that are used in context to today's scenario. And outcome could be an incidence of healthcare acquired infections that have been taken care of. So whenever we are talking about the outcome measures, what we need to be very clear is which perspective are we trying to take care of. Whether we are trying to take care of the perspective of the patient, whether we are trying to take care of the perspective as per the clinician, we are trying to take care of the perspective as per the physiological functions, or we are trying to take care of the perspective as per the caregiver. So it will all depend upon this particular aspect, and it is always outcome is based upon an individual priority basis over what is your research question and what are the various goals that you want to be take care of. So the ultimate aim is to have a safety culture and to have its clinical utility and cost effectiveness. So I hope I am able to clear some air on this particular outcome measures, and maybe we could have more sessions on these outcome assessment, because there are a lot of things that need to be interpreted, and maybe uh, it is not always possible to have too many things on one particular session. So till that time, till we meet again, uh, I wish you all a happy day and have a happy experience. So if there's any queries, I would be very happy to take care of it. Thank you so much for your patient hearing.